Hello everyone, this is Dr. Humanist again. Let us now discuss about adrenal insufficiency. So we'll see acute and chronic. So first we'll see acute. So acute adrenal insufficiency is also called as adrenal crisis, which is followed by non-specific complaints. So the symptoms are due to both glucocorticoid deficiency and mineralocorticoid deficiency. That we'll see what are those symptoms. And so patient even like it will start with postural hypotension and might land up into hypovolemic shock also. Okay, other symptoms and the symptoms might mimic the acute abdomen also. There will be abdominal tenderness, nausea, vomiting, and fever. Okay, so sometimes patient might be confused to have some neurological condition because of the symptoms like altered mental status, decreased responsiveness, might even progress to stupor and coma. So what are the triggers? Incurrent illnesses like any infection or hyperthyroidism, any case, or any surgical or other stress, and hyperthyroidism because there is an increased glucocorticoid inactivation. Signs and symptoms. Firstly, because of glucocorticoid deficiency, symptoms like fatigue, lack of energy, weight loss, anorexia, myalgia, joint pain, fever, normochromic anemia, slightly increased TSH, because there is a negative loss of feedback inhibition of TSH release because of the decreased steroids. Hypoglycemia, as you know, steroid causes increased blood sugars. Low blood pressure, postural hypertension, hyponatremia, because there is a feedback inhibition of ABP release, that is antidiuretic hormone. So symptoms because of mineralocorticoid deficiency. Symptoms like acute abdomen, as I said, abdominal pain, nausea, vomiting, dizziness, postural hypotension, salt craving because of hyponatremia, hyperkalemia, low blood pressure, that is postural hypertension, and increased serum creatinine mainly due to volume depletion. So this is because of loss of aldosterone function. Aldosterone, what it does, as you know, sodium and water retention. So in the deficiency, there will be more water loss, and there will be hypovolemia and hyponatremia and hyperkalemia. Okay, so caused because the symptoms because of adrenal androgen deficiency, like lack of energy, dry and itchy skin, especially in the woman, loss of libido, loss of axillary and pubic hairs. Other symptoms can be hyperpigmentation or hypopigmentation, that is nothing but alabaster colored pale skin. So based on, depending on, is it primary adrenal insufficiency or secondary adrenal insufficiency. Hyperpigmentation will present in primary adrenal insufficiency, as there is a problem in adrenal glands. There is excess release of ACTH. With that, there is release of POMC, that is propionmelanocortin derived peptides. So this will cause hyperpigmentation. Whereas in secondary adrenal insufficiency, there is a problem in pituitary or hypothalamus. That's why there is a deficiency of this hormone, propionmelanocortin. Right. So that's how we can differentiate primary or secondary adrenal insufficiency clinically. So this is the overall approach to the patient with adrenal insufficiency. So when you're suspecting adrenal insufficiency, you have to measure morning 9 a.m. plasma cortisol levels. So depends on cortisol levels. If it's less than 100, that means it is clear case of adrenal insufficiency. If it's between 100 to 550, so then you have to perform a test, that is synactin test. Okay, in which what we are stimulating, like it is a synthetic ACTH, we are stimulating the adrenal glands by external ACTH, and we'll see the response of adrenal glands to it. Okay, next is more than 550, then the adrenal insufficiency is less likely. We have to see for other causes of the symptoms. So how to perform the short synactin test? Okay, so what we do is we'll give, here it is given, we'll give, this is synthetic ACTH 250 micrograms. Okay, at the and you have to measure the cortisol level 3 times, first on the baseline before giving the drug, after that 30 minutes and 60 minutes you have to measure. So when is the test positive? When the cortisol levels at 30 minutes and 60 minutes are less than 500. So even after stimulating the adrenal glands with the synthetic ACTH, the adrenal glands are not producing cortisol levels, more than 500, normally. So that is when we say there is a adrenal insufficiency. Now, in the both the cases, like less than 100 and positive synactin test, we have diagnosed it as adrenal insufficiency. Now we have to differentiate either it is primary or secondary cause, isn't it? So for that we have to see the ACTH levels. So ACTH levels are elevated in primary cause. As we know, there is adrenal gland deficiency, so ACTH will be released, right, as a positive feedback. Then what are the causes? Addison's disease, like because of autoimmune destruction, tuberculosis, infection, infiltration, or congenital problems. And if ACTH is reduced, that means there is a secondary hypoadrenalism, that is because of problem in the hypothalamus or pituitary, or due to long-term steroid use. And you have to see for what are the causes hypothalamus by doing MRI imaging and see and rule out the pituitary causes. So this is the diagnosis in little detail. So short course entropin test, which we discussed just now, will give the synthetic ACTH and check the cortisol levels at 30 and 60 minutes. If it's less than 500, that is positive. Now what happens is during early stage of HPA disruption, that is hypothalamo pituitary axis, within like 1 month of pituitary insufficiency, patient may respond to exogenous ACTH stimulation, right? So that might falsely negative test of the coarse entropin test. In that cases, what you can do is you can check for insulin tolerance test. So what we do is we'll make the patient overnight fasting, and then we'll give a dose of insulin, okay, to the patient and see for the response. So insulin, what it does, it causes hypoglycemia, and you know that hypoglycemia will physiologically release the steroid, increase the cortisol levels. If there is no response or very decreased response to the hypoglycemia that is caused because of insulin, that means there is adrenal insufficiency. But there are certain contraindications, like the patient who cannot tolerate the hypoglycemia, or there are no signs and symptoms, like in the case of diabetes mellitus. Patient won't be having signs of hypoglycemia, but they can land up into severe hypoglycemic symptoms like coma. So in that case, we have to be very careful. Other diseases like cardiovascular diseases or history of any seizures, or in the cases of limitations of random serum cortisol measurements. So limited diagnostic value due to diurnal rhythm of cortisol secretion is there, that's why. And one more thing is, patient with secondary adrenal insufficiency may have normal baseline cortisol levels also, but they fail to respond to appropriate ACTH stimulation. That you have to keep in mind. Follow-up test we can follow by plasma ACTH measurement. Now, to primary, because we are ruling out primary versus secondary, and in follow-up also we can see the response as we do in thyroid abnormalities, like we compare with TSH levels. Additional tests like plasma renin measurement we can do to see especially the mineralocorticoid deficiency, steroid autoantibodies if you're suspecting for autoimmune adrenalitis, adrenal imaging to rule out any hemorrhages or infiltration or masses. Okay, very long chain fatty acid measurement. This is for one specific syndrome or disease, that is X-linked adrenoleukodystrophy of adrenal gland. So in the males it causes because it's X-linked inheritance. Other than that, we can go for MRI in the cases of secondary adrenal insufficiency to see any problem in hypothalamus or pituitary. Okay, we have to suspect for pituitary apoplexy and with adrenal insufficiency symptoms, like if a sudden onset severe headache is there or history of head trauma, then you have to suspect for pituitary apoplexy and you have to test for that. Now treatment, first treatment is rehydration, because as we saw there is a hypovolemia. So at the rate of, you can use normal saline at the rate of 1 liter per hour, and you have to do continuous cardiac monitoring also. Other than that, glucocorticoid replacement, bolus injection of 100 mg followed by 200 mg over 24 hours. So total 300 mg we are giving within 24 hours. Next is mineralocorticoid replacement. Only high dose hydrocortisone when you are giving, you don't have to necessarily replace the mineralocorticoid. Okay. So in high dose hydrocortisone will cover the mineralocorticoid deficiency also. Now coming to the chronic adrenal insufficiency, guys. So there is not the critical patient will be having fatigue or hyperpigmentation like the symptoms, and we have to keep on continuous treatment therapy. For that, glucocorticoid, we have to give 15 to 25 mg hydrocortisone orally, 2 to 3 divided doses we can use. And you have to increase the dose in some stresses like pregnancy. You have to increase the dose by 50%. And the dose, at least half of the dose, suppose you are giving 20 mg, so 10 mg should be given in the morning and 5 mg afternoon or evening you can give, because this is to mimic the physiological or circadian release of the cortisol levels. You have to avoid long acting corticosteroids like prednisolone, dexamethasone. So we can monitor for history, examination, weight, blood pressure when you are putting patient on steroid therapy. We can also see plasma ACTs, 24 hours urine 40 goals, and serum cortisol day curves are less reliable, but we can do. You have to screen for autoimmune thyroid disorders spectrum, like autoimmune spectrum disorders, like Hashimoto's can be there, so that you have to rule out. Other than that, as we are keeping patient on chronic steroid, you have to check for bone mineral density and evaluation, as steroids causes osteoporosis, isn't it? Stress related dose adjustment, like in the cases of fever is there, okay, and then any surgeries are there, or pregnancy, you have to increase the dose. So in that cases, like vomiting, surgery, trauma, we have to give the dose of 100 mg hydrocortisone followed by 200 mg, what we just now saw in the acute cases. In the cases of stresses, we have to give that dose. And also we have to tell the patient to carry a hydrocortisone self injection emergency kit, and we have to tell the patient how to take it in the cases of emergency. Then next is mineralocorticoid deficiency. As we are giving the low dose hydrocortisone, so patient might need the fluorocortisone. So mineralocorticoid replacement will be needed in primary adrenal insufficiency. Okay, so dose is 100 to 150 microgram fluorocortisone we have to give. And even you have to increase the dose during hot weather. As there is hot weather, there will be more hypovolemia, so we have to increase the dose by 50 to 100 micrograms. And you have to monitor by checking the blood pressure, electrolytes like sodium, potassium, and renin also you have to measure. For androgen replacement, what we can give is DHEA. For the females especially, who are having symptoms of androgen deficiency, like lack of energy or other symptoms, as I discussed, dry skin, pruritus, itching will be there. Other than that, loss of libido, those kind of symptoms you have to consider starting on DHEA. Okay, and you have to measure for DHEA levels, androstenedione, testosterone, and sex hormone binding globulin 24 hours after the last dose. Thank you.